Welcome to the Pediatric Stroke Network and our educational series. I'm Mara Yale. I'm a parent to a child who's now 15 and had a perinatal stroke, and I also lead this network and our educational program. So I'm going to share my screen and give you an overview of the program before we hear from Cynthia with a lived experience about the topic of the day, and then Sudha will share more about the research and what inspired it. So, as I mentioned, we are running this pediatric stroke network. It's really for families affected by pediatric stroke or brain injury. Today's topic is play as therapy, and Sudha will go into more detail about her particular research project called Jumpstart, and what the acronym means and what the ideas and principles are behind that. So I wanted to contextualize this education program and why we're doing this at all. As you know, stroke that happens in infancy or in utero or in childhood can have a profound impact on the whole lifespan. And typically, we might interact with clinicians, doctors, and therapists early in the journey and for a few years, sometimes a whole lifetime. But most of the care is not happening in a clinical setting. So we're trying to enrich the lives of these children and their families. And just to remind you, everything that we're sharing is for educational purposes. This becomes important when we get to the question and answer discussion. We request that you ask questions in a way that can be educational for everyone. If you have a medical question about your child, please hold that and reach out to your healthcare providers. So we're very proud of the educational program we've built over the last 6 years, and I just want to highlight some aspects of that. Each topic is quite specific. It might be about um, video gaming as a fun and therapeutic activity, or constraint-induced movement therapy, or vision, cortical visual impairment, or adaptive sports. So each topic is narrowly focused, but the body of topics has grown over the years, and we now reach an international audience. And we, as today, partner with many speakers from different organizations. And we're calling this a network because we're really building a web. Um, and the web it interfaces families, children, clinicians, researchers, and private and public entities, nonprofits, and other organizations that support this population. And the relationships are reciprocal. So um, Sudha came to our in-person Play to Thrive event and used that to help recruit children for her research trial. And we've done this with several other collaborators. So we're always happy to have new collaborators and keep spreading the good education. In terms of what's coming next, all of our past sessions, including today's, are up on our YouTube channel and our webpage. And we now have 3 events in the month of May. You may know that May is Pediatric Stroke Awareness Month. So we have virtual webinars like this one today, one on dyslexia and other specific learning disabilities on May 2nd at noon Eastern Time, one on constraint-induced movement therapy on May 31st, and then our 4th annual in-person Play to Thrive event is on May 10th. That's a Saturday. And we welcome families from anywhere in New England who are able to get to the Boston waterfront. So thanks so much. And I'm going to stop my share here and welcome Cynthia, who's going to share the lived experience perspective of these ride-on cars.
Great. Thank you, Mara. Hello, everybody. Good to see you. My name is Cynthia Bonadiaz. My son Noah was diagnosed with cerebral palsy, hemiplegia in May of 2022 when he was only 4 years old. He was accepted into a birth to three program when he was one for delayed walking and speech. During those years, no one really picked up on his cerebral palsy issue. It wasn't until Noah started tripping over himself that we decided to investigate a little bit further. We had made an appointment with a pediatric orthopedic doctor at the time with Connecticut Children's Medical Center. And during that appointment, he told us that what Noah actually had was not an orthopedic issue, but in fact a neurological issue. We were then referred to neurology. And after meeting with their doctor, Dr. Yorns, we began to understand that Noah's challenges, things that we hadn't really picked up on before, were all tied to this to cerebral palsy. So, for instance, right, like Noah had zero feelings on his right toes. He always told us that they felt funny for a 4 year old, right, as much as he could describe the feeling. And so, like a tingling sensation, a numbness feeling, and we always found him itching that right foot, but we didn't really understand why, right? And so we also started to notice his normal standing stance with him having his right arm sort of like you know at a 90-degree angle, position at a 90-degree angle, and always like super tight over his body. So anyway, but since our journey has started, Noah, so at the time of 4, when he was diagnosed, we started a journey, and he's had a couple of times a procedure that is called chemodenervation procedure, if I'm saying that properly. He's had it now a total of 4 times. And what this procedure is essentially it's injecting Botox into different areas of his leg or his arm in order to loosen that muscle, that tightness that he has on there. And so at one point, Noah did have an AFO brace for an entire year, which was his kindergarten year. And if you were to ask him, it kept him from being able to keep up with the other kids in the playground. So it was a little bit of an uncomfortable situation for him. Noah does have PT services on a regular basis. And we found that keeping him active through physical activities such as taekwondo, swim, and soccer, as well as basketball, which is something he loves, were some of the things that were very helpful for him. In particular, though, we found that Taekwondo has really helped Noah strengthen his right side, which is the side that he has the issue on. Just in general, like core muscles and things, and just the way the master works with him on that. So now, through all this work that we've done with him, both clinically, medically, physical activities, Noah's able to move the toes on his right foot, which is a huge accomplishment, and he's having some control over them. So he's definitely progressed very well with that. Um, so Noah was part of Noah participated in the Yukon study where he was part of the speed group, which focused on having Noah utilize solely his right hand to drive the car and maneuver around obstacles and complete challenges with a focus on utilizing only his right hand, right? And that's one of the things that, like, on a day-to-day basis, Noah doesn't really use his right hand, right? He's all lefty. So prior to doing the study, Noah wouldn't really utilize that hand, like we said. And however, as the study progressed, we saw that Noah started to utilize his right hand more and more, and was very confident when reaching out and grabbing for different objects. I believe that the speed study test really helped to train Noah's brain, and to push him to utilize his right hand in day-to-day activities, and also strengthening it. I think that the study is very important for kids with hemiplegia, as it's non-intrusive like other treatment methods, and it yields great results. Just in this short period of, I think it was 6 weeks that we were doing in the study, we found that, Noah is able to utilize the right hand just as much as he's using the left hand at some from our observation, and I'm sure Professor Suda may have some data on that. But so Noah himself will tell you that now he uses his right hand a lot more than he used to, which is it's become a great thing around our household. That's all I have to share in regards to that.
Thank you so much, Cynthia. Thanks a lot for that perspective and for your kind words. I'm really excited to have all of you here and to have so much interest on the topic. I This is something which I'm very passionate about. So I'm looking forward to share our work and our research with you all. So give me a second while I share my screen. Can someone just let me know if you're able to see my screen?
Looks good.
Okay, perfect. So thank you so much, Mara, and thanks for the opportunity. Like I said, I'm really excited to present the work that our group has been pursuing over the last 5 years, that is looking at trying to use playful methods to get children with unilateral cerebral palsy and children with hemiplegia to use their affected upper extremity. Now, the title of the talk is Jumpstart, so joystick mediated upper extremity motor play. And I will say at the outset that we do not see this as a replacement to conventional therapy. We are seeing this as a way to encourage children to use that affected side in meaningful ways, in goal-oriented ways. We're trying to make therapy fun for kids with hemiplegia. Now, the results that I will present today are coming from a majority of children with unilateral cerebral palsy, but we've also worked with children who've had hemiplegia as a result of pediatric onset conditions like stroke or hemorrhage or brain injury. And we do find that this particular intervention does work with kids with hemiplegia because of other reasons, might not be just at birth or in utero. I would also like to say that there are photos and videos in the presentation, and we've taken permission from families to use these photos purely for scientific and educational purposes. So just to give you an outline of the talk, I'll tell you a little bit about myself because I've had an interesting journey and I would like to share why I came upon this particular research project and what my background has been. I want to tell you a little bit about my research. We'll talk a little bit about our pilot studies and findings from those studies, and then also looking forward, what are the next steps for this particular research? So coming to my academic journey, I come from India. I got my bachelor's and master's degrees in physical therapy from India with a master's specialization in neuroscience. From there, I took the journey and came to the US to get my PhD in kinesiology at the University of Connecticut. My doctoral work was really looking at trying to develop movement-based interventions for children with autism and early detection of autism. So I've spent about a decade of my work really with kids with autism. I then moved on to do a postdoc at the University of Delaware, which is where I was looking at the needs of adults with autism, trying to understand what sorts of interventions they are receiving or what sorts of supports are needed for families. I then went back to India and that is where I did another postdoc. I worked a little bit in a hospital in a pediatric rehab setup there, but then I got another postdoc at the Indian Institute of Technology. Now, this particular school is actually an engineering school, and I was housed within the School of Design. But I got this fantastic opportunity to work on a UNICEF-funded project to develop an assistive technology, specifically an open source augmentative and alternative communication tool for kids who are non-verbal or minimally verbal. So that was my introduction to this realm of assistive technologies and trying to use technology to empower children and families. Following that postdoc, I came back to the US in 2019. And since then, I am an assistant professor in the physical therapy program at the University of Connecticut. I'm the director of the Reinvent PT Lab. And the goal of our lab is to develop playful interventions as well as assistive technologies to empower children and families living with developmental disabilities. So with this particular background about myself, let me give you a little bit of a background about our research. So, cerebral palsy is known to be the most common motor disability, which is considered to be a disorder of movement and posture. Currently, there are 1 in every 345 children in the US diagnosed with cerebral palsy. And in general, the global burden of cerebral palsy is quite high, and there are considerable healthcare costs associated with this condition as well. Now, there is one specific type of cerebral palsy, which is the population that I primarily work with, and these are kids with unilateral cerebral palsy, right? So, kids with hemiplegia, which means one half of their body is significantly weaker than the others. And with these kids, several times you see that the upper extremities are more involved than their lower extremities, and that significantly impacts their activities of daily living. Now, since this is a condition which is um, something that develops very close to birth. It can happen in utero. It can happen, at the time of birth, or it can happen very early on in childhood. Children develop this condition or this phenomenon that we call as developmental disregard. And what I mean by that is that children learn to rely more on their less affected side. Like Cynthia was mentioning before, Noah really has learned to use his left side for most activities of daily living, right? And so that sets up a vicious cycle where children tend to rely on that less affected side more and more, and they kind of disregard their more affected side, and that makes it difficult for them to actually gain skills on that affected side. And this kind of affects all of their activities of daily living, whether it is self-care, like, putting on a t-shirt, tying shoelaces, whether it is related to play or whether it is related to academics, right? And as a result of this impacts their activities of daily living. It impacts their participation as well. Another thing that we need to consider is when we are thinking about children, it's not just the sensory motor skills that are affected. In childhood, all of your developmental domains, whether it is cognition, whether it is emotional development, whether it is social communication development, all of these skills develop together. And so if there are impairments in the social sensory motor domain, that is going to affect the child's overall development and participation within their community as well. Now, so what can we do about this? There is evidence that suggests that task-oriented interventions that are provided at a very high intensity are really effective in getting children to use their upper extremity more. So there are approaches, like Mara was saying before, constraint-induced movement therapy, bimanual training. These sorts of approaches are really trying to get children to use that affected side in a very intensive manner for about, say, 60 to 90 hours of practice that is needed to see improvements in children's affected arm use. But the reality is that children really do not receive this recommended dosing in clinical practice. In clinical practice, children might receive maybe a couple of hours of physical therapy or occupational therapy every week. And this falls severely short of what is recommended by the evidence. So we have this service gap where children read much more than what they are receiving to see those meaningful gains in upper extremity function. So that is one gap. The other gap that we all know, which is really important, is the issue of child motivation, right? We are talking about kids here. When you're talking about adults, you can tell adults, hey, this is good for you. So you got to do this therapy, right? And adults might actually comply. But when you're thinking about kids, kids will do things that they find fun, that they find engaging. So child motivation and investment in therapy is a very big factor, which is tied to their improvements in terms of therapeutic outcomes. So it's challenging when you think about these intensive interventions of 60 to 90 hours. Many a times it is very challenging to retain child interest during such intensive intervention. So what we thought is that there is a need to develop more innovative, playful ideas that are intrinsically motivating for children, so that are fun, so it doesn't feel like work, it doesn't feel like therapy. And these sorts of interventions can help diversify the current options that are available in terms of rehabilitation, right? So our goal is to try and come up with these child-friendly options that are family-centric, that can involve caregivers, that are fun for kids, and can also serve a therapeutic purpose. So far, we've talked about these two gaps. One is related to services provided for children and what is needed to produce those improvements. And the second we've talked about is trying to maintain that child engagement. So, how do we address these gaps? We can address it, like I was mentioning before, by trying to develop these child friendly therapies that are age appropriate, that are inclusive, that foster child autonomy, and therefore are motivating for kids. Secondly, to get that dosing of 60 to 90 hours, we really need caregivers to be part of the solution. We need them to be involved in designing those interventions as interventionists. So we need programs that do not add on to the burden of families, but in fact can be easily integrated into family routines that are easy to implement for families. And then thirdly, we also need programs that are versatile, that are adaptable, right? We are talking about families that might have different situations, whether, depending on what their living situation is. We want programs that are versatile for use across multiple settings, that can be individualized or tailored to the specific child and family needs. So what is our solution? So one of the solutions, oops, I'm sorry. So one of the solutions that we are proposing is we are saying that these joystick operated ride on toys are age appropriate solutions. They are accessible, they are affordable, and they might be perhaps used as therapy adjuncts to boost that dosing. And at the same time, since they are fun, whether it's a child with or without disability, probably these might be interventions that children are really finding fun, engaging, and intrinsically motivating. So that's sort of where we started. And the way that we've developed this particular program is we have taken commercially available ride-on toys. So I wanted to show you the two pictures of the toys that we've been using so far. We've taken commercially available ride-on toys that come with two joysticks, and by working with biomedical engineering, we have changed the control so that now you can have this toy be operated in a single or a dual joystick mode. And when we operate it in, say, a single joystick mode, we can turn on the joystick on the child's affected side and turn off the joystick on the child's unaffected side. So, for example, with Noah, we turned on the right joystick and turned off the left joystick. So now the toy can only be operated with that right joystick, thereby encouraging him to actually use that side to drive the toy and to engage in fun games. So the program that we've come up with is called as the SPEED program. So we call it as the strength and power in upper extremities through exploratory driving. And this particular program has two key ingredients or two main elements. One is navigation, and the second is we get children to engage in different types of object-based upper extremity tasks. So with navigation, children are encouraged to go through different paths of different shapes, sizes, different surfaces. We encourage obstacle avoidance. So you can see examples of the different types of paths that we get children to traverse with. So there's a lot of, obviously there's a sensory motor piece to it, but there's also a lot of planning. There's a lot of motor planning going on when children are trying to figure out how to get themselves or how to navigate through spaces of different constraints. In addition to that, we are also, the program also has object-based upper extremity tasks, and those tasks involve both gross motor movements as well as fine motor movements. So getting children to reach, to catch, to throw, to push, to pull, to grasp objects. So we try and involve different types of playful tools to get them to engage in these activities. The best part about this program, we think, is that it is versatile for use across a variety of different indoor as well as outdoor settings. And we've done this in multiple types of settings, as you can see in the pictures below. Next, I want to show you a little bit small snippet of the program itself. So this is a young child that we worked with. She had a diagnosis of ataxic cerebral palsy, and I have two videos. One is when she was just starting out, and then the second one is, more towards the end of the training. So I hope that you can. So you can see here that we have a specific path that is demarcated. She was driving from point A to point B. Um, so each of these sessions has a specific theme. So here the theme was minions. So she had to, go from one part to the other, save the minions. So you can see that she was pulling something. She's trying to grasp objects. She's trying to save the minions. There's anyone there? Let's try to stay on the path, okay? So for her, she had right-sided weakness. So again, we had turned on the right joystick. Although the left joystick is here, it doesn't really work. Even if she tries to push it, it won't work. And kids very easily and very quickly learn to use that right side. So it's really amazing to see that despite that disregard, with a little bit of encouragement, you can actually get them to start using that affected side. I'm going to, for the interest of time, I'm going to show you the other video, which is now in the 12th session. So in the first video, I don't know whether you were able to notice, she did require support. She did require my assistance. By this session, which was session 12, at the end of the 6-week program, she was able to drive the toy all by herself. She was able to reach for objects, grasp it. Horse. Very good job, Libby. Look, now the merry-go-round is complete. How cool is that? That's wonderful. All right, so now what we got to do is wait a minute. Let's wait for Miss Steph to go ahead. Yeah. Okay. Now we got to again have the parts. Here, we got to go to the tree. And she also graduated from driving on hard surface to grass, which is a lot harder because there's a lot more resistance. You're making me run today. This was too fast. So again, just an example of the type of training activities that we would do, the navigation piece and the object-based upper extremity tasks. I want to also spend some time to just tell you about our journey. How did we, start this particular line of work? So we started this work with typically developing children, where we wanted to see whether typically developing children can learn to drive the toy using their non-dominant side. So we tried this with them, and we found that even with a few minutes of free play and exploration, typically developing children can learn to use their non-dominant side to control a single joystick to drive the toy. So that gave us confidence, and then we started our studies with children with hemiplegia, and we started this as part of a constraint-induced movement therapy camp. And in fact, some of the clinicians at the camp are actually here. So it's great to share our findings with them as well. But we started it as part of a CIMT camp. The camp was provided, 5 days a week. It was an intensive 3-week camp, 5 days a week for 3 weeks. And we incorporated the ride-on toy training as one of the activities of the camp to just get a sense of, is this feasible to deliver? What is the kind of feedback that we're getting? How do children perceive it? How do caregivers perceive it? How do clinicians perceive it? So we did that in the camp for multiple years. We delivered the training. And then more recently, we also trained the clinicians to deliver the training. Because ultimately, what's the goal of this research? The goal of this research is to have multiple stakeholders deliver these type of tools, right? So whether it is clinicians, whether it is caregivers, whether it is teachers. So we sort of saw how it was possible for clinicians as well to deliver this training. We then transitioned to, like I was mentioning, caregivers. So our next study was a home-based intervention or a community-based intervention, which was researcher caregiver co-delivered. So twice a week, we went and delivered the training, but then we left the toys with the families for the entire 6-week duration. And then we encouraged caregivers as well to deliver the training to see what are the barriers to implementation from the caregiver side, or what are some positive points of this particular intervention to check the feasibility. And then finally, now we are in this particular phase, and I'll talk more about this randomized control trial, which is what NOAA is actually a part of. But here we are comparing two different types of interventions. One is the speed intervention, and then we are comparing it to standard of care occupational therapy, which is what children receive to improve their upper extremity function. For the purpose of today, I'm actually going to talk about the results from our previous study, which is the community-based intervention where we delivered this in collaboration with caregivers. But before I go to that, I do want to summarize some of the things that we've learned from our camp-based studies. So first thing that we learned was it was feasible to deliver this in camp settings, both by the research team, but also more, we could train clinicians to deliver this type of training, and they were able to deliver it with fidelity. It was very well received by children, caregivers, and clinicians, and I will share with you some of the feedback that we received. But in general, it was possible to deliver. It was well received. And then in addition to all of the camp activities that were done, when we incorporated this speed program, children actually showed improvements in both unimanual as well as bimanual function. And these improvements extended beyond the duration of the camp day, right? So children were able to, like Cynthia shared, children were able to learn these skills in the context of the ride-on toy training, but then they were able to carry it over outside of outside of that particular training. So when they were out of the car as well, clinicians and caregivers noticed that children were using that affected side more for daily activities. We also found that children got significantly better at driving the toy from the first day to the end of the training. They got much better in terms of maneuvering and controlling their arm, as well as in those motor planning abilities. And then finally, this was something which led to high levels of engagement. Children were really very much on task. They did find it to be fun and engaging. So now I'll talk a little bit about our latest study that we have recently completed last year. The goal of that particular trial was to assess the acceptance, the feasibility, and satisfaction associated with the home-based delivery of this ride-on toy intervention from the perspective of children as well as caregivers. And secondly, we also wanted to see if it is efficacious in improving motor function on that affected side in children with hemiplegia. So this was a single arm trial. We had 15 children with hemiplegia. In terms of their severity levels, they had mild to moderate level of impairment. You can see the age range is 3 to 8 years. And in terms of the design itself, this particular trial was where children served as their own control. So we started off with a pretest, which we call as time point 1. Then children went into a 6-week control phase. This is where we did not intervene, but we were keeping track of the type of conventional therapies that children were receiving. Then we got them back to do the time point 2, which was our midpoint assessment. Then we did the intervention phase. So this is where, in addition to everything that children were receiving, they also received the ride-on toy training program. Then we call them for the post test, where we did the standardized motor assessments. And then finally, we had a 1-month follow-up. So with this kind of design, you can see how we were able to sort of tease apart what is the effect of the conventional therapy. And then when we add the speed program, what are the incremental effects? Is there value in adding the speed therapy in addition to whatever children are already receiving? And then we could also see the carryover effects. In terms of our assessments, given the aims of the study, we assessed feasibility as well as we assessed preliminary efficacy. So how feasible is it to deliver this intervention? What was the adherence? What was the retention rate for our participants? What was the feedback that we were getting from participants in terms of their satisfaction? And then we also had a bunch of different measures that were looking at that preliminary efficacy piece in terms of standardized tests. We had objective measures. We also collected data from caregivers in terms of their perceived benefits. For the purpose of this particular talk, I'm going to restrict myself to some of the measures related to feasibility and preliminary efficacy, but I'm happy to take questions if people have questions on other measures that we collected. So let's start with the feasibility measures, right? So, in terms of our feasibility measures specifically related to adherence and retention, this particular table here is talking about both the researcher-led sessions and the caregiver-led sessions. Just as a reminder, remember this was an intervention which we delivered in collaboration with caregivers. So we delivered some sessions, but we also left the toys with the parents to deliver their sessions. So in terms of adherence, we found high levels of adherence in terms of our researcher-led sessions, as you can see here. Um, and in general, we gave up to around 7 hours of dosing over that 6 week duration. When we look at caregiver-led sessions, we see that it's more of a mixed picture, right? In contrast to researcher-led sessions, caregiver-led sessions, there was a 50-50 sort of thing, and I'll tell you the reasons for that as well. But caregivers were able to deliver the intervention up to around 3 hours or so. The caregiver sessions we anyways encouraged them to try and get it into the child's routines. It could be, even 5 to 10 minutes here and there, but trying to get that dosing as much as possible. We also gave caregivers and children some questionnaires, and we asked them about child enjoyment. We asked them about their desire to repeat the training. And these are the kind of findings that we have here. So on our y-axis, we have the proportion of participants. The green indicates high levels, the orange is medium levels, and the blue is low level. So the proportion of participants who gave us specific responses. So what you can see here is both children as well as caregivers felt that this kind of a speed training program led to really high levels of engagement in most cases. In terms of their desire to repeat, it was 100% of families actually wanted to repeat this again, and high levels of children also wanted to repeat the training, which was a very positive sign for us. In terms of ease of delivery, this was where there was a little bit of a mixed picture, where you see that some families, they found it easy to implement the interventions, versus others did have some challenges. And we delved deeper into what those challenges are, so that in our future trials, we can try and make things easier for families. So we collected some open-ended feedback from families that I would like to share here. One of the things that we asked them is, what are the positive aspects of this program? What did you like about the program? And some of the feedback that came across was really enlightening for us. That one of the things that parents said is that children do not see this as work. There's a lot of it's fun, it's exciting. So they don't really necessarily see this as therapy. They also found that the environment was very immersive. They felt that the fact that this particular training really focused on the upper extremity and got them to use that affected upper extremity. Because when you think about a child, they're receiving so many interventions, and the focus of those interventions might be different, right? Versus just trying to get that 1 hour of practice of just using that affected arm was really huge for parents. We also asked them very specifically, how does this program compare with all of the other interventions that your child is receiving? And again, some of the things that came up was that hands-on practice, the fact that it challenges them to use their arm in different ways in which the child hasn't used it. The fact that it is versatile, it can be adapted to different settings. Those were some of the big things that came out of this particular feedback. And then very important for us was, what are the challenges, right? So what are some barriers to implementation? And this is where one of the biggest things that came out was scheduling, that children have very busy schedules, parents are working and they have very busy schedules. And sometimes it's hard to fit this training into their schedules. The other constraints were related to child being fatigued, or also dependent on weather, where, some of this specifically in the outdoor environments can be challenging, although we have tried to figure out, indoor spaces that could be used, whether it is the children's church, whether it is getting permission from school, whether it is some sort of a community center. So those were some of the challenges that came out of this particular exit questionnaire. So this was related to feasibility. So we did find that it was feasible. It was well accepted by families, but there are several challenges that we still need to work on as we move forward with this intervention. Coming to preliminary efficacy. So this is where we were interested to see, okay, it's well and good that this program can be implemented in the community, but does it lead to improvements in upper extremity motor function in these kids? So we used a bunch of standardized tests, but I'm going to share findings of one particular test, which is called the Shriners Hospital Upper Extremity Evaluation. This particular test includes 16 bimanual activities. You can see some of the types of activities in the pictures below, stringing beads, folding a piece of paper, opening a jar. Those are some examples of some activities that children were required to do. And when they were doing these activities, we looked at how likely is this child going to use their affected side to actually engage in that activity. So that was called as a spontaneous functional analysis, or SFA. So the spontaneity of use of that affected side. And then the second thing that we looked at is what is the positioning of the joints in that affected arm as the kids are doing those sorts of activities. So we collected these data at all 4 time points of the study. And what we did find is in this table. So I know it's a lot of numbers, so I'll try and break this down for you. So we found that when we add our ride-on toy training to conventional therapy, it led to significant improvements in their spontaneous use of that affected hand. So from pre to post intervention, you can see that there are significant improvements in terms of both their spontaneous use as well as in the positioning of their upper extremity. And what was really encouraging for us is the large number of children who actually did follow these group trends. And also, more importantly, even after the intervention was terminated, we did find that these improvements stay, right? They carry over even after the intervention ends. And that goes back to what Cynthia was saying before, that during the intervention, we try to get them to develop awareness of that side. We try to get them to develop strength and confidence in using that affected side. Once that happens, children tend to start using that side more and more during daily activities. And that sort of sets up the cycle of them continuing to improve even after the intervention has been completed. The other thing that we asked parents also was, what is your opinion? Like, did you feel that children improved in terms of their motor function? And overall, what this graph shows you is that parents unanimously did feel that there were improvements across different domains of motor function. Most parents felt that the greatest improvements was in fine motor function, followed by gross motor and their use of that arm outside the training context, and to a lesser extent in bilateral coordination skills as well. We also used another questionnaire, which is called as the Able Hand Kids questionnaire. This particular questionnaire asks parents to rate their children's independence and their ability to complete bimanual activities. It includes things like putting on a shirt, zipping up a jacket, pouring water into a glass of, pouring water into a glass, right? So it includes all of these different activities. And we again collected these data both during that conventional intervention that they receive, and then during the intervention phase as well. And what we find is that children showed improvements across both those phases, right? Both during when they were receiving conventional OT and PT, and also during the intervention phase. But the improvements are larger during that intervention phase, and more children improve in that particular phase. So what this tells us is that when you add this sort of playful, engaging intervention that boosts the dosing, and that is something that children really enjoy participating in, it helps to increase that dosing. It helps to increase that function on that affected side, not just while they are driving the toy, but also outside. The final measure that we used to look at motor function is an objective measure. So this is something that we call as activity monitors or actigraph watches. So we had children wear these accelerometers on both of their wrists during the training session, but also at baseline. And the reason for doing this is we wanted to see what is the level of asymmetry between their arms, right? And where they start off with, and does the training actually impact this asymmetry? Now, these devices, they are like your Apple Watches, but what they do, they're research grade, they collect acceleration data, and then that acceleration data is converted into activity counts. It sums the acceleration across the X, Y, and Z directions. And finally, through that software, what we get is how much time were both those arms, were they sedentary, were they engaging in light activity, or were they engaging in really moderate to vigorous activity? That's what we get across both of those arms. So let's take a look at what we found, right? So I have two graphs here. One is looking at their non-dominant or their affected side, and the second one is looking at the dominant upper extremity. Now here, red means that this is the time that the child spent sedentary. So they were really not moving their arms at all. Light activity, right? So they were moving it, but to a lesser extent. And then moderate to vigorous activities where there was a lot of movement in those arms. So when you look at baseline, what we see is not surprising, right? That children tended to have greater sedentary time in that affected or that non-dominant upper extremity compared to the dominant upper extremity. But what was encouraging to see is that over the course of the intervention, children actually increase the amount of moderate to vigorous activity on that affected side. And in fact, you're seeing that the profiles are becoming more symmetrical, going back to what Cynthia said, that Noah is starting to use that his righty as much as his lefty, right? That is huge. To get that symmetry in that arms is really huge. And that's something that we found on the objective measure as well. So now I would like to just summarize what I've talked about today. Overall, from our past pilot studies, what we found is that when we add the speed training using these ride-on toys to usual care, it leads to greater improvements in their motor function. You start seeing them use their spontaneously use their affected side more, not just while driving the toy, but also outside in their activities of daily living. You see more of that independent use of that affected side. In general, our program, we think, since it's based in theoretical frameworks of motor learning and motivation, we think that this offers a very engaging opportunity for children and families to participate in activities that are aligned with children's likes and interests. It fosters that motivation, and therefore it doesn't feel like therapy. It doesn't feel like a chore. It gets children to use that in more fun ways. It's also versatile. It can work in outdoor as well as indoor environments. And so we think that is a big strength of this therapy. We also think that the fact that it can be delivered by clinicians, it can be delivered by families, makes it something that can be easily integrated. You do not need a lot of training. It's something which is easy to implement in a variety of different environments. So far, however, despite these positive findings, our work is limited because we have a small sample size. We've done this only for a 6-week training program. We did not have a control group, right? All of our studies so far were single group designs. But even from those studies, and specifically coming from the feedback that we're getting from our stakeholder, we do think that ride-on toys might be used to incentivize the use of the affected arm. They are excellent opportunities, specifically for kids who have those interests, to expand and extend therapy beyond school or clinic-based settings, to get therapy into children's homes, and to get the entire family, not just the child, but also the siblings, peers, to be involved in that intervention. In terms of our future directions, this is the study that is currently funded through the National Institutes of Health. Here, our plan is to recruit 30 families, and we will randomize these families to either receive the speed training, which is use of the ride-on toys for a 6-week duration, or to receive the craft training, which is modeled around conventional occupational therapy. Both groups do involve playful activities. They are focusing on upper extremity function, but the way in which we are doing it is different. One is using the ride-on toys, the other is a more seated control. And then we'll have our post-test, and we'll again have a 1-month follow-up. If any of you would like to be part of our studies, please feel free to reach out to me via email, and I will be happy to tell you more about the study. Finally, I would like to thank our funders, which is the American Academy of Cerebral Palsy and Developmental Medicine, as well as the National Institutes of Health. We've also received support from the company that makes the toys. They've graciously donated some toys for us to do this work. We are at this kind of a forum, and I cannot end the talk without making an appeal and a request to all of you. In light of the federal landscape, there are a lot of funding cuts. We do not know whether our research will receive renewed funding. So, making an appeal to all of you, if you think that this research is valuable, please contact your representatives and try to advocate for this type of work that is going on. And then I would like to thank, everyone who's involved in this research. I always say that it takes a village to do this type of work. And so I want to give a big shout out to the children and families who've participated in our studies, the clinicians from the lefty and righty camp of Connecticut. Some of them are here, as well as all of the wonderful partners that we have that make this work possible. And then finally, I have to thank all of my undergraduate and graduate students and research staff in our reInvent PT lab at UConn who've helped us do all of this work. Thank you all for your attention. This is my bibliography, and I open it up to questions, but please feel free to reach out to me, even if there are questions which pop up later on. Please feel free to reach out to me. This is my email address. Thank you all for your kind attention. I'm going to stop sharing so that I can see people and if there are questions.
Thanks so much, Sudha. And what we're going to do, the way we handle these questions is we invite you to put them in the chat or just to raise your hand, a regular hand or a virtual hand. Uh, and we'll have a discussion. If you're able to come on camera, that's best, and it really helps promote the sense of community. So are there any questions or observations? And we have clinicians in the room as well. Catherine.
Hi. Oh, that was a wonderful presentation. So informative, and it covered full ground, so comprehensive. So thank you so much. It's so exciting. What a challenge. I'm glad you mentioned the current climate of funding, and it's so overwhelming that we don't day to day. But anyway, I noticed in one of the study results that you said that the children were not, it appeared that the children reacted to working on this with their caregiver or parent. And I wouldn't be totally surprised they have more fun with somebody else generally.
Right. Thanks, Catherine. Thanks for bringing that up. Thanks for your kind words. And yes, that was some of the not with everyone, but certain families. The kids, the parents. Actually, it was parent feedback where the parents said that my child does not want to do this therapy with me. They would rather do it with anyone else. And that goes to the point that parents and caregivers are serving multiple roles, right? And so here we are sort of asking them to serve yet another role of a therapist. But I do strongly believe that the caregivers know their kids the best, and the children are with their caregivers for way longer than me as a therapist can be with them. And that's the whole point, that can we make this as something that the child will say, hey, you know what, I want to drive the toy. It's not seen as therapy at all. And so it is more of a fun activity that the entire family engages in. And we've had those sorts of experiences where siblings will do this siblings will do this together, and it's almost like a competition. It's also so inclusive. It sort of normalizes, because children with or without disabilities find this equally engaging. And in fact, we've had, like, although this study was 3 to 8 years old, we've had even 13, 14-year-old children want to participate in this intervention, and having participated in the intervention. And for them, the motivation was, I want to drive the real car. So this is practice for me to drive the toy. So to your point, yes, absolutely. In certain cases, when children start seeing that this is therapy or work, it might be daunting to do that. But our goal is, how can we make this better? How can we make this more fun? And I will also acknowledge that it's not a one size fits all, right? So I'm not saying that this is going to be the solution for all of our children, but the point is, can we diversify interventions? Can we provide families with multiple options, and they can pick and choose based on what is best for their child and for their family?
May I ask a question about within the responses? I know it's a study, but my thoughts go to, okay, do you have a workbook or are you in the process of compiling a workbook that you share with a caregiver or parent that gives some ideas? And have you had any feedback about new ideas that they've come up with while they're trying to implement this with their child?
Absolutely. Yes to both. Because we do provide a manual, which, again, we do not want this to be prescriptive.
Mhm.
Like I said, the caregivers know their children the best. We've had families, and some of them are actually on the call, where mom would say, I'm going for a walk. And I'm walking, you can drive the toy with me. So they have like sort of done the rounds of the neighborhood with the child driving the toy. But we've also had families where they've said, give us some ideas, like give us some themes, tell us how to make the courses, tell us how to position props. So we provide both options. We leave it up to caregivers to decide what they would like to do, but we do have manuals, we do have activities developed, and we do provide supplies to families so that they can implement the intervention. And we also give them flexibility. Some families have done this when the child is waiting for their school bus. Like I was telling you, someone, it might be like they're taking their evening walk. So parents have made it, caregivers have made it work in different ways. And the second question, in terms of feedback, absolutely. I think that there is this intervention is not developed, right? Like it's not like it's done. It is an ongoing process. And in fact, again, one of the parents who gave us feedback, I can just remember off the top of my head, she's on the call as well. And some of their feedback was relating to try and add more textures, try and add more sensory activity. So yes, the point is, every single time, every single family that participates tells us something, and we learn something from them, and we try and implement it in our next intervention, even with the next family, not just like leave alone the next study. But I think we are trying to co-develop this with all of the stakeholders involved.
Keeping it fun is just so important. So
Yes,
I think that's really
absolutely.
remarkable. It's wonderful. Thank you so much.
Thank you. Thanks for your
Buddha, I
feedback.
have a few questions or topics that I want you to expand on. One is to explain from your perspective the value of variety, and then I will have Dr. Mussolino chime in on that as well.
Absolutely. So, um, I think variety, diversity is the key, right? So, um, I mean, novelty is always a big thing, right? So at different ages, the children's needs differ, and the therapy has to sort of keep up with them. So, like I said, right now, we have developed this intervention, we've developed these tools, but we're always trying to find ways to make it better. Whether it is perhaps we add resistance. So as the kids get better, they've done this, they've become really proficient in it. Then maybe we can add, resistance to make it more fun, to make it more challenging for them. But going back to your point, Mara, I think, like I said, I acknowledge that this is not a one size fits all, and this is not the solution, right? It is trying to develop this suite of options, whether it is ride on toys, whether it is video games, whether it is, some kind of adaptive sports opportunities. What are different ways in which we can engage our kids to have fun, but at the same time work on these therapeutic goals, or getting them to participate, is a big thing. So I completely acknowledge that.
Patty, can you chime in on that from your perspective?
Yes, and I was waiting for Sudha. Thank you so much for the work that you've been doing and the way that you also approach this webinar. Because I do think what we are providing is this framework, and the framework is what you're saying. It's like therapy in the environment of a therapist, hospital-based, clinic-based, outpatient-based, or even school-based, has a limited repertoire. And what you're trying to do is enhancing that repertoire of experience and motivation. And I think that is something that then the families can do. And I totally agree with you, not giving parents an extra role, But in reality, it's the most empowering thing that I have experienced for parents to have, which is a framework of what can I do that is part of life, daily activities, games, cooking, whichever it is. We just talked about toys. We've been talking about sports and adapting the sports. And in this case is, what is it that we need to look as a family or as a provider to enable the access to these fun activities, motivating activities, so the day-to-day becomes also an opportunity to rehab. And I cannot emphasize more, and there's several of our webinars as well to go after how the brain learns, thus require the multimodal, like meaning several modalities at the same time, sensory, visual, spatial. And in this toy, for example, it particularly puts together all of that. But the most important thing, the motivation. We also know the brain doesn't develop or learn if it's under stress or a significant amount of frustration. Not that mistakes shouldn't happen. That's the only way to learn too. So that's why all this availability of experiments and kids being able to diversify and try different things at different times, even day by day, week by week, not just by age, and are critical. And I think it's been what I find so helpful about the way that you presented it, which is this is one, but there are many other ways that therapists and families and providers can be thinking together, even with the community, on how to enable access to these very multimodal, fun, playful, age-appropriate, and safe experiences. And the research will take a long time to catch up with us, meaning to prove what are the benefits and how does it work and for whom.
Right.
But at the same time, with those parameters that we just talked about, there is no reason why not to do something that we can clearly see is enabling the experience to learn and use a part of the body or learn a modality of function. And even if the social part is what we're getting out of this, is incredibly meaningful and is important now. So those are my 2 cents on how exciting it is to me to see people taking on understanding this, but at the same time doing it with the full conceptual frame, the now and the need, and they're having this be a fun activity for the kids. So I'm glad we connected, and these patients are also benefiting. I saw a question that I think you want to ask Mara as
Yes.
well
Yes.
about the
Um,
devices.
Yes.
yeah, there are
Yes.
two
Yes.
questions in the chat. One,
I
Tara,
think,
can
yeah.
you ask your
Yes.
question?
I think I see the questions, Mara. So should I go ahead and answer them?
Well, let's see if the person can come on camera and ask, because that helps for the recording. The recording doesn't include the chat. Tara, if you're not able to ask, I'll ask. Um, so this was an interest in buying the cars and being able to essentially switch on which joystick is working.
Right. So at the moment, these toys are commercially available, but like Ni mentioned in the chat as well, we are modifying those toys. So that modification is something where we are collaborating with biomedical engineering. Now, the goal, the ultimate hope is similar to the Go Baby Go project, which is a nationwide project where they modify ride-on cars to provide it as a mode of mobility for kids who are non-ambulatory. Similarly, the model there with the Go Baby Go is now they have instructions available, and then you can have like high school students under supervision make those modifications and then provide it to the community. And there, each state has a Go Baby Go chapter, and there are donor programs also there. Similarly, the goal ultimately of this intervention is, if this turns out to be something which is fun, which is acceptable to stakeholders, and which is efficacious, then the goal is to try and come up with a way to make it family accessible to families. And that would mean putting together instructions. I've also had some conversations with the company, and the company representative is going to be here today, but unfortunately could not. But trying to see whether they can make these modifications at the outset, at the company level itself, involved? Can they make these changes so that you can operate it in a single and a dual, and then you can provide it to families? Because right now the cost of the toy itself is around $250, but there is significant cost associated with modifying those toys. So how can we reduce those costs, or can we have, insurance cover it? So those are all things down the line. And going back to what Mara was saying, research actually takes a lot of time. So it took us 5 years to get to this particular point. So research, unfortunately, it does take time, and you need to provide evidence in a very systematic manner. Um, but that's the ultimate goal, that we would like to make it available to families.
Thanks so much. Jordan, I see you came on camera. Can you ask your question?
Sure. Hi, Doctor. Is it Srinivasan? Did I get
Yes,
it?
yes.
Oh,
Hi, Jordan.
hello.
Nice to
Thank you.
collect again.
I know had been emailing. Thank you so much for your research and devoting 5 years carrying it so far, and your orientation, which is how to make therapy fun for kids. So important. This would be right up my son's alley because he's like been obsessed with all things motor from like day one, from watching a fan when he was months years old. But he is 10 years old. So I was wondering whether you could share the criteria for your current study for age and location and what time frame.
Right. So this particular study that we have ongoing right now is actually for kids between 3 and 9 years of age.
His birthday was last week.
Yeah. Um, it is the location is it is I mean, we go out to families' houses.
Mhm.
So although we are based in Connecticut, we are willing to drive up to a 1.5 hour radius, and we have in fact worked with families in Massachusetts in the past. So the therapy or the intervention itself is actually provided within the family's community, whether it's home or school. But we do ask them to come to UConn for the testing sessions so that we can have
Mhm.
that standardized. That is three testing sessions over a period of 3 months. So like once a month that the family might be coming. The intervention itself is for a 6-week duration. Twice a
Mhm.
week, we go to the families' houses to provide the training, and then we leave the materials, whichever group the
Yep.
child falls in, that I do not have control on. But we leave the materials with the families so that they can also practice more. And yeah, so that's where it is. And in the past, our justification for being able to travel like 1.5 hours was because we got multiple families in the Boston area, and so I could make a day trip out of it and then see the families back to back. Yeah, so that's
So an
where.
hour and a half. Okay, great. And also thank you, Cynthia, for sharing your child's experience. My second question is around, did you see any differences in efficacy from when the sessions were care provider given or therapist given that you trained versus researchers? Like what's the magnitude if you saw any differences?
Right. So that's a great point. And that is something that we have to still look at, Jordan. We are still, I mean, we know that the clinician versus the researcher, I do think that is comparable. But with the caregivers, just because there's so much variability in terms of caregiver delivery, we have not yet got
Yeah.
the power, or we do not have the sample size yet to be able to ask those questions. What we are asking is, if you have collectively, if you combine the researcher and caregiver, like does the dosing matter, right? Like those sorts of questions we are starting to get at. But what you raise is a very important and a very valid point. But we are still at the starting phases. Hopefully with this randomized control trial, we will be able to more control, or we will have better information in terms of the therapies done by the caregivers versus the researchers, and then we will be able to ask those questions. But at the moment, at least in terms of clinicians and researchers, we do find that they are both able to deliver the intervention, and it does show improvements. But again, know that is, you're combining conventional therapy with this ride-on toy intervention, right? So
Mhm.
our current study, our randomized control trial, is the first time where we will be able to tease apart the effects of the ride-on toy compared to conventional therapy. So far, we are just sort of pitching it as an adjunct, which it is, which ultimately in the real world we do see it as an adjunct, but
Mhm.
we've not been able to ask that question of how does it, compare to conventional therapy.
How about between the researcher and the therapist one? Was there real difference in efficacy or not really?
No, no, they were both leading to improvements.
Thank you.
Yeah, absolutely.
So I'm going to ask one question and then Catherine has another one. Um, are you tracking the usage with technology or with some kind of manual log?
Yes. Yes, we are doing both, Mara. So the toy itself does have sensors on it. So whenever the child pushes the joystick, it is collecting data on how much time that the toy was used. So we are collecting that, and we also ask caregivers, clinicians, whoever are the ones who are delivering it, to also keep up with the manual log of whenever they did the interventions. And parents have been really great in terms of keeping up with that information, and we have the right on toy usage to kind of corroborate that information as well.
Thanks. Catherine, what's your question?
Uh, Thank you. Some things came to mind. I was thinking about the add-ons and how this, as it gets more developed, grows with the growth of the child and the,
Right.
age-appropriate stimulation, whatever it is. And I said that I was looking at this, and my interest is the siblings or other friends, are they finding it fun to try? And is there a way that this could be developed towards it's just like you're getting a bicycle and it doesn't have to be looked at that it's for special needs kids or anything else, because there's enough challenges and eventually add-ons that keep, like adding resistance and making sort of fun ways of using it, that it becomes more mainstream. Because I get down to also, they could have them at the library, your local community, and just people sign up like they do for, I don't know, a tennis court or borrowing equipment.
Yeah, absolutely. Thanks so much for that question, Catherine. That is the goal. And in fact, I will say that um, I do not really see this as a special toy at all, because in our experience, siblings, especially, they are very much involved, and sometimes they are actually a little jealous that they are missing out on this whole intervention. And we've seen this across the board with the families that we work with. So in fact, they come up with an agreement that, okay, you drive it for this much time and you drive it for this much time. And at that point, we have had to keep, as a parents, to keep a note, like which part of this training was, done by the child with a disability versus the sibling. So absolutely, I do not see this as something which is, only specific for kids with disabilities. In fact, that's the ultimate hope, that we can develop it in a way that it is easily accessible, and both kids with and without disabilities could use it. In fact, that normalizes it even
Yes,
more,
yeah.
because there's a
No
competition,
stigma.
there's inclusion associated with it. So that's the goal. I wish I could do all of this right now, right?
I
Like,
know.
that's the thing. But
It's
as a
exciting.
researcher, it has to go through, and that's where it has taken us a lot to get even this NIH funding. And with what is going on at the federal level, it's really scary, and it is anxiety provoking that it takes so much time to get to this particular stage. And then when you have the momentum, if things are cut off, or like, they're not supporting this, then all of us working are really passionate about this. So I think that we really, as a community, need to advocate for the importance of this work, for the importance of helping our kids and families.
Thank you.
Absolutely. Looks like we may be winding down with questions. There's a request to send out the flyer, and I will do that. I think I have it from you, Sudha. If not, I'll get it from you to send out to everyone who registered and push out to our social media channels as well. Thanks so much, and we hope to see as many of you as possible in May for Pediatric Stroke Awareness Month. Thanks again and have a great day.
Thank you so much, Mara. Thanks everyone for being here. Thank you. Bye.